Hi there. This is Greg Karagesian recording the voiceover for fluids and electrolytes. Let's just have a review of this module, starting with this slide. So we're gonna talk about how fluids are distributed throughout the body, whether it's in the blood vessels, intravascular, in the tissue between the blood vessels and the cells, which is called interstitial, and in the cells, intracellular. So we're going to talk about fluid shifts. We're going to speak about and review electrolytes, important electrolytes. Sodium and potassium are definitely extremely important electrolytes for a number of functions in the body that we'll go over. There's also calcium, magnesium, phosphate that also have roles in the body, of course, and chloride. But we're going to try and separate which ones are more important and which ones are a bit less important. Which ones we get worried about when they're abnormal, and which ones we aren't as concerned about.
Okay, so let's just talk about water balance a bit. The human body's made up of about 60% water. Okay, so about 2/3 of us is water. And water is in pretty tight parameters. The body wants to keep us in water balance. And at the same time, it wants our electrolytes to be in pretty tight parameters, such as sodium and potassium and chloride and calcium and magnesium. So there's often a balance between water balance and electrolyte balance. Okay, so for example, if you consume tremendous amounts of salt, the body has two choices. It can either have you drink more water to dilute the sodium, or it can try and excrete the sodium in the kidneys, okay? Because all of these electrolytes, and the water included, are trying to stay in proper balance. And we'll talk about the different compartments where water exists in the body, okay? What about water loss? So the main way that we lose fluid or water are the kidneys, right? By the production of urine. And the kidneys are highly regulated. They're regulated by hormones that can reabsorb the water back into the bloodstream. And there's also hormones that can encourage more fluid loss. So the kidneys are constantly receiving messages about how much urine to produce to either get rid of more fluid or to reabsorb more fluid back into the bloodstream. The gastrointestinal tract, under normal circumstances, has a small amount of water in the feces, but most of the water has been reabsorbed by the colon. So one of the main functions of the colon is not only just to store fecal material, but it's also to reabsorb water. That's one of its main functions. And then there's other losses that we call insensible losses, meaning that we can't really measure them with input and output measurements that we do in a hospital. And that's through the skin and also through the lungs. Okay, so in terms of sweat through the skin and just breathing, you're actually breathing out humidified air. So those are two areas where you have insensible losses. Okay, so another slide on water. So what are the causes where you could lose excessive fluid? Well, definitely vomiting and diarrhea would be one where you're losing not only fluid, but you're potentially losing electrolytes as well. Okay, blood loss, say from hemorrhage. you're going to lose whole blood in a hemorrhage. Profuse sweating is going to cause you to lose fluids. High fevers, you tend to lose much more fluid when you have a fever. In fact, young children that have high fevers can become dehydrated because they're sweating and they don't have a lot of fluid reserve. Tissue burns, so significant skin burns, tend to weep a lot, and the blood vessels under the burn become very permeable, so they're leaking out lots of fluids onto the epidermis. So burns or burn victims tend to lose a lot of fluids. The use of diuretics is another way of losing significant fluid. Nasogastric tubes, so a tube that goes into your stomach for us to suck fluids out of. We keep track of how much fluid we are removing from the stomach so that we can give back the fluid, say, through an intravenous line. Okay? Alcohol is a bit of a diuretic, so that can lead to more water loss. And not drinking water, right? So not maintaining hydration will lead to dehydration. So what are the symptoms of water loss or dehydration, or for that matter, low blood pressure, because you are losing your fluid volume? Well, you can be hypotensive, so low blood pressure, which is going to cause you to feel dizzy because the brain's not getting enough blood pressure and blood flow. Weight loss, that's a very accurate way of knowing how much fluid someone has lost, say from the use of diuretics. So we measure somebody's weight very closely when they're on diuretics, for example, in the setting of heart failure. Your heart's going to be tachycardic because it's trying to pump more fluid when the blood pressure is low. You're going to have really concentrated urine because the kidneys are doing everything they can to reabsorb the fluid from the nephrons. So your urine will be dark and concentrated. In severe dehydration, you'll have very poor skin turgor, so that when you pinch your skin, it doesn't immediately return to normal. And that's called skin tenting, where the skin will stay up because the skin is so dehydrated. Okay? Headaches, that's just going to be from lack of fluid in the vascular space and low blood pressure. Muscle cramps can occur from poor blood flow, but also often you have lost electrolytes as well. And electrolytes are very important for normal muscle function, so that can lead to muscle cramping. So let's look at fluid distribution in the body. Where is all this fluid? So fluid is really broken down into compartments. And we're going to talk about two compartments. So the intracellular fluid or compartment, and that's where approximately 2/3 of our fluid is, within the cells. And remember, within the cells is where we tend to have higher concentrations of potassium compared to the extracellular fluid. So the extracellular fluid comprises about 1/3 of your body fluid. And what is the extracellular compartment? Well, it's all the fluid between your cells, so the interstitial fluid or the interstitial compartment, and the vascular compartment or the intravascular compartment. Okay, so extracellular fluid is basically where all the other fluid is that isn't in the cell. So in the intravascular space and the interstitial space. Okay, and it typically has higher concentrations of sodium and chloride compared to the intracellular fluid. Okay, so just think of the extracellular fluid as the interstitial, which is all of that fluid between your cells and within the blood vessels, the intravascular. Okay, and all the cells in your body are constantly pumping out sodium into the extracellular compartment. And they're keeping higher concentrations of potassium within the cell, the intracellular compartment. Okay, let's talk about the concept of capillary pressures. Because really what the body wants to do is to get blood that's being pumped from the heart into the aorta, and then it's going to go through many different arteries to get to different parts of the body, and the arteries are going to become smaller and smaller, so we'll call them arterioles. And finally, when those blood vessels get to organs all around the body, such as the brain, the kidneys, the heart itself, the skin, the digestive tract, it's going to become little tiny vessels called capillaries. So there's going to be pressure within the capillaries that all started with the pumping of the blood from the heart. Okay, so we're going to call that pressure the hydrostatic pressure within the capillaries, and that's what's going to allow some of the fluid or the blood that's in the capillaries to go out of the capillaries into the tissue space, which is called the interstitial space. And that fluid is going to feed the cells, right? Because it's filled with oxygen and nutrients. Okay, so that's how fluid or blood, gets out of the capillary with the hydrostatic pressure. Okay, let's continue on through the capillary until it gets to the venous side. Okay, because on the other side of the capillaries, they're going to turn into little tiny veins called venules, and then they're going to get bigger and bigger as they meet up with other veins. So the pressure has gone down significantly because a lot of the fluid has left the capillaries due to the hydrostatic pressure. So the hydrostatic pressure in the little veins has been reduced, but it still wants to get some of that fluid back that went into the interstitial space. And how does it do that? Well, it uses oncotic pressure. So in our bloodstream, we have large proteins, the most important one being albumin, which is made in the liver, and that never leaves the bloodstream. It never leaves the capillaries. So as the blood goes through the capillaries and releases fluid into the tissues, the albumin stays in the capillaries, and at some point the hydrostatic pressure gets lower and lower and lower, but the oncotic pressure to pull fluid back into the tiny veins, the venules, is now allowing fluid to return to the venous side. Okay, so and that's exactly what the capillaries want to do. They want to send out fluid to feed all the cells, and they want the fluid to come back into the capillaries on the venous side so that it can then return back to the heart. Okay, we're going to still continue talking about capillaries, but let's just talk about two other concepts that'll help us understand the movement of water. So osmotic pressure and oncotic pressure. So osmotic pressure is really the movement of water from an area of low concentration, say of sodium, for example, to an area of high concentration of sodium. So the water wants to move to a more concentrated area to dilute it and to make it even. That's osmotic pressure. Okay, and it doesn't have to be sodium, it could be any electrolyte. But sodium is a good example because let's say you have a cell that suddenly fills with sodium. And now water is going to follow the sodium into the cell to dilute it, and the cell is going to swell. It's going to become edematous, okay? And that'll make sense when we're talking about cellular edema in another module. Okay, oncotic pressure is the movement of water back into the capillaries because albumin and other large proteins never left the blood vessels. So there's a pull for water to go back into the blood vessels to dilute or to try and even up the difference of the concentrated albumin. Okay, so water moves from an area of low concentration or low solutes, such as salt, to high concentration of solutes. And what determines this term called osmolality, which is very similar to osmotic pressure, is your sodium and your glucose. Okay, so sodium and glucose, typically water will follow them. Okay, so let's look at the two cylinders at the bottom there. So we have a cylinder on the left which has a higher concentration of albumin on one side of a membrane that only allows water to go across it. So the water is definitely going to go from left to right because there's more solutes or there's more albumin on the right side. Let's look at the second cylinder. So the second cylinder, one part of the cylinder has filled with more water in order to make the albumin the same concentration on each side. And that's what capillaries do with albumin. The capillaries don't allow albumin to leave the blood vessels. So what happens is the water wants to go back into the blood vessel to make because of the oncotic pressure. Okay, so I think this slide is going to help you understand how blood gets to capillary beds in all the different organs of the body and releases fluid into the tissue, and then as the capillary continues and goes to the venous side of the capillary, the pressure is going to the fluid is going to go back in to the capillary. Okay, so on the arterial side, say you have a hydrostatic pressure of 40. Remember, the systolic pressure at your heart could have been 120 or 130 systolic. But it had to go through all these arteries and little arterioles and capillaries, so it lost a lot of its pressure. But let's say it still has 40. Well, the oncotic pressure from albumin is always going to be the same. It's 25, okay? Because albumin isn't changing in the capillary. It's staying there. It's not changing its amount. So it's always going to have a oncotic pressure to come back into the capillary of 25. Okay, so since the hydrostatic pressure is 40, it's going to allow fluid to go into the tissue, the interstitial tissue. okay? And it's going to release its glucose, its oxygen, and all the other nutrients to feed cells. And as it does that, it's losing hydrostatic pressure. So as we go to the venous side, you'll see that the hydrostatic pressure has dropped to say 10, but the oncotic pressure is 25. So there's going to be more force for fluid to go back into the capillary because of the oncotic pressure due to the albumin. Okay, so it's a perfect system. It forces fluid out on the arterial side of the capillary, and it sucks fluid back into the capillary on the venous side. Okay, so that it can return back to the heart for another round of pumping. So otherwise, if this system didn't exist, the fluid would just fill and fill and fill with fluid from hydrostatic pressure. So the capillary needs a way to bring the fluid back on the venous side, okay? And that's albumin that's produced in the liver. So you can imagine if you no longer have albumin because your liver is failing, you're going to get diffuse edema and swelling all over your body because you're losing your oncotic pressure. Okay, so let's look at this question. Solutions that have a greater osmolarity or osmolality than the intracellular fluid are called hypertonic, hypotonic, hyperactive, or isotonic. Well, if they have a greater osmolality or osmolarity, they're very similar, then they're going to be hypertonic, meaning they have more concentration of whichever solute we're talking about, so they're hypertonic. If they had less concentration of, say, electrolytes, such as sodium and chloride and potassium, they would be hypotonic. Hyperactive has nothing to do with this, so we'll leave that one. Isotonic just means that the concentration of solutes within the fluid or the solution is the same as the intracellular fluid. Okay, so this will matter when we're talking about intravenous fluids. What kind of intravenous fluids do we use? So if we use, say, for example, a hypertonic fluid, and then the hypertonic fluid, as it's going through the capillaries, goes into the tissues. So now there's more concentration of solutes in the interstitial tissue. It's going to pull water out of the cells. It's going to shrink the cells. If you have a hypotonic solution, and that makes its way all the way to the capillaries, then into the tissue from the capillaries, well, that has lower concentration of electrolytes, so it's going to go into the cell and cause cellular edema and swelling. If it's isotonic, then it's going to be even. It's not going to go into the cell anymore, and it's not going to force the cell to have fluid come out of the cells. Okay? Okay, so important to understand that concept of hypertonic versus hypotonic versus isotonic, right? So if I have a really salty solution in a glass, say, so I have a glass of water and I poured tremendous amounts of salt into it, then it would be hypertonic. If I had just a glass of water and I didn't add anything to it, it wouldn't have many solutes at all. It wouldn't have many electrolytes. It would be hypotonic. If I added just the right amount of sodium and chloride and potassium that equaled the intracellular compartment, it would be called isotonic. Okay, so here's another slide on helping you with this concept of isotonic. So isotonic just means the same concentration, the same tonicity. Uh, and if we're talking about an isotonic solution that we can give in terms of intravenous fluids, we're typically talking about 0.9% normal saline. So normal saline has sodium chloride in it. So it's basically just salty water. We use it all the time. And at the concentration of 0.9%, it's isotonic to the intracellular compartment. Lactated ringers. Again, another solution that we make up that's isotonic to the interstitial fluid or the intracellular fluid. And what's inside lactated ringers? Sodium, bit of potassium, some calcium. Okay, and it's made to a concentration that's isotonic. D5W is considered isotonic, but D5W is just water with some sugar, dextrose. And because the dextrose breaks down and gets consumed so quickly by the body, essentially you're giving water. So D5W is considered an isotonic solution, but as soon as it's put into the body and the body breaks down the dextrose, it's a very isotonic solution. So we don't use it very much for maintaining patients on intravenous fluids. We use 0.9% normal saline or Ringer's lactate because they're not going to cause the cells to swell and they're not going to cause the cells to shrink, right? They're isotonic. Hypotonic, so meaning less solutes within the solution that we're giving, within the IV solution. And an example of that is half normal saline, so 0.45% normal saline. A hypertonic solution, so much higher solutes. An example of that would be 3% normal saline, so a much saltier solution of normal saline. Or if we add D5W, which is just, again, dextrose in some water, but we added it to normal saline, that's also hypertonic. It has more solutes in it, okay? So at the bottom, you can see that if we give someone a lot of hypotonic solution in an IV, we're going to cause the fluid to go into cells, right? Because it's hypotonic, and it's going to go to an area of higher concentration of solutes, which is within the cells, and they're going to get cellular edema. Isotonic, the cells are going to stay the same. Hypertonic, the cells are going to give up some fluid to try and dilute the very salty solution that's being given. So you'll get cellular shrinkage or cellular dehydration, okay, because it's pulling water out of the cells. And all of these solutions are used in different circumstances, but I'm going to tell you the most common solution we use for maintenance of giving someone, a patient, to maintain their hydration are isotonic solutions. Now, say for example, someone has swelling in their brain. They've had a head injury and they have a lot of swelling in the cells of their brain, in the neurons. Well, we could potentially give them a hypertonic solution, such as 3% normal saline, and that is going to pull fluid out of the swollen cells in the brain, right? So sometimes in head injuries, we will use 3% normal saline to try and pull some of the edema out of the cells and reduce the overall pressure within the brain, because we're pulling fluid out of the cells and into the vascular space. So it'll reduce the pressure in the brain.